Yesterday, and we still have a great panel today. Lots of great sessions, ending off the day with a panel of health journalists similar to what we had last year. It is my great privilege to be able to introduce you to the new CMC'S director, Mary Mayhew. She was just appointed, in October, right? Right, so she's brand new. So we are very excited to hear from her and hear about her plans and her vision in the future. In 2011, Mary was appointed by Governor Paul LePage in Maine to be the commissioner of the Department of Health and Human Services. That's the big umbrella agency there, with everything from their Medicaid program, Adult Protective Services, TANF, food stamps, etc. Under her leadership, she focused a lot on program integrity and fiscal management. Prior to her appointment as the commissioner of the Maine DHHS, she was a senior health policy advisor for the LePage administration. And before that, she was with the president of the Maine Hospital Association. So without any further ado, I'd like to introduce you to Mary Mayhew. Thank you.
Thank you. Well, good morning. Hello, everyone, and welcome to the last day of the NAMD Annual Conference. First, I want to thank Matt, his board, and the staff at NAMD for your continued partnership and for putting on this important conference. I have enjoyed and appreciated the meetings that I have had with state leaders and the opportunity to have some of the discussions that we've been able to have through our office hours, but I have to say I'm disappointed that I've missed many of the incredible sessions that Matt and his team have lined up for this conference. I have heard incredible feedback about the panels and the discussions. Over the last 2 days, together with my team at Medicaid, we have had the opportunity to meet with individual state leaders and their teams to talk in greater detail about our partnership, our commitment to that partnership, and to address state-specific issues and challenges. Those discussions have helped to highlight the importance of robust communications, which I know you all can appreciate, doesn't necessarily mean that we agree on everything, but getting it all out on the table and having that opportunity to talk collaboratively. And certainly those conversations, importantly, have highlighted the principles established by this administration and voiced repeatedly by our administrator, Seema Verma. Seema's vision is clear. Establish greater flexibility for states to manage their own programs, create strong accountability for the effective and efficient delivery of high-quality care and services, and strengthen program integrity to ensure the long-term viability of this vital safety net program. Yesterday, Secretary Azar underscored that we have an obligation to help those who need it most, and we need to ensure that we are building a Medicaid program that is sound, solvent, and helps all beneficiaries reach their highest potential. Administrator Verma has worked tirelessly to establish those fundamental and foundational principles. Today, we are serving over 70 million individuals in the Medicaid program and spending nearly $600 billion to provide effective, high-quality health care and services. The needs across the continuum are great. We want to make sure that the 88-year-old grandmother is receiving timely supports in her home, that the 28-year-old with schizophrenia has effective medication management and timely access to critical mental health services, that the 85-year-old couple with the 40-year-old adult son with Down syndrome has peace of mind, that when they're no longer able to or no longer around, that their son is receiving critical services and that they can depend on the state to meet his needs. That the 8-year-old is receiving good quality primary care. That the 38-year-old with diabetes is not in and out of the emergency department because of a lack of effective chronic disease management, and that someone who is battling a substance use disorder has access to substance abuse treatment when they're ready. I say all of that because I think it goes without saying that we probably have the market cornered for acronyms, right? That our regulatory language is often complicated, and we spend a lot of time talking about technology, and we use terms that we may all know, but I want to make sure that we're always putting a face to the lives, to the families, to the individuals that we are here to serve and support. And for the work being done, for the money being spent, can we answer the questions of whether health outcomes have improved, are individuals getting access to critical services, is the system integrated, are we efficient in the use of taxpayer money? To that end, since the beginning of this administration, CMS has been working to increase state flexibility and provide regulatory and administrative burden relief. As I said, CMS wants to empower states to work with their communities, your providers, our citizens, to design a program that meets the needs of the states and your diverse populations. We understand that states are on the front lines and know best how to effectively support their Medicaid beneficiaries. The challenges are often great, the demand urgent, and the state resources frequently constrained. We want to provide states with greater flexibility to move swiftly in embracing best practices in care delivery to timely address critical and emerging needs and to effectively manage programs in the best interest of improved outcomes and efficient use of taxpayer money. As part of this work and with the guidance of Administrator Verma, CEMA has taken a number of steps to promote systems that work best for those populations. So I want to talk briefly about the 1115 demonstrations, and there's been a lot of discussions over the last couple of days. So as you know, one of the ways that we're providing states with flexibility is through our new, broader view of Section 1115 demonstrations. States are now able to focus on evidence-based interventions and to drive better health outcomes and quality of life improvements. Both the administrator and I are committed to working with state officials requesting flexibility to continue to provide high-quality services and support upward mobility and independence and advance innovative delivery system and payment models. We want to make sure that the state strategies under Section 1115 demonstrations align with the core objective of the Medicaid program, serving the health and wellness needs of the nation's vulnerable, low-income individuals and families. Last year, we announced a new policy to combat the opioid crisis by increasing access to treatment options through a substance use disorder waiver. Let me just say we are so thrilled with the number of states who have come forward, who want to demonstrate and provide this, and we know that there are many more. And of course, importantly, we need to identify the best practices that are emerging out of those models, get that information quickly out to all of the states so that we can replicate those successful outcomes. I also want to acknowledge the recently passed opioid legislation, which does include a new state plan option that will be available beginning October 2019. We are still assessing this legislation and look forward to providing additional guidance, particularly in how that state plan amendment will intersect with our substance use disorder waivers that have been such an important part of responding to these challenges. Yesterday, as Secretary Azar announced, we, because of the tremendous interest, released a state Medicaid director letter providing guidance to states on how they may establish innovative service delivery systems to provide services and supports for adults with serious mental illness or children with serious emotional disturbances, including in settings that qualify as institutions for mental disease. I believe that was at about 9:20 yesterday. Is Judith Cash, is she in the room? Judith, I think at about 9:30 there was a line forming in front of you to get those waivers submitted. So we're ready, and we know how critically important this is, because as I'm sure, let's put this all in terms that everyone can relate to and appreciate, either because of your professional experiences or from personal experience. I know how many calls I received about someone stuck in an emergency department for days and weeks in need of access to residential mental health services, or a child placed in a facility out of state, away from family, away from their community, and certainly from county jails, struggling because of individuals with mental illness who find themselves in the criminal justice system because of a lack of access to those services. So we are extremely excited about the opportunity this new demonstration will afford states to effectively and timely respond to those critical needs. I want to stress that this new opportunity will also require significant engagement around the entire community mental health system, because we want to make sure that individuals are able to timely transition to appropriate levels of care. And I also appreciate that with these requirements will come increased monitoring and evaluation to make sure that we are able to demonstrate that we are achieving those objectives. And much of this, as you know, comes back to, do we have reliable data that we can use to evaluate the system's performance? Another initiative that we certainly have heard from a number of states on is our community engagement initiative, in which we currently have 4 approved waivers and 10 pending requests. Almost a year ago, CMS provided states with the opportunity to promote work and community engagement among their working-age, able-bodied adult beneficiaries. As the Secretary and the Administrator have frequently said, we are committed to helping individuals on a pathway out of poverty and away from governmental dependency to improve health and financial independence. We want every individual to be supported in fulfilling their potential. As part of this initiative, we are seeing exciting results of partnerships at the state level spurred by these waivers. For example, states are engaging with their community colleges and technical schools to connect Medicaid beneficiaries with new educational opportunities and job skills. The demand for healthcare employees, personal support staff, welders, electricians, plumbers, auto mechanics is significant. And it is exciting to see these innovative partnerships with Medicaid at the table, supporting these effective pathways to employment. State Medicaid programs are partnering with nursing homes to provide CNA training for enrollees. They are collaborating with locally based and federally funded career centers to support access to resources around resume writing, interview skills, job search. And we have also launched a learning collaborative for states that serve as an opportunity to share best practices, lessons learned, and provide a platform to encourage intergovernmental collaboration with sister agencies. All of these innovative efforts and your ability to timely respond to the challenges in your states is completely dependent upon our responsiveness and the efficient processing of your requests, and we take that very seriously. Over the past year, CMS has taken steps to decrease the amount of time to process and improve certain routine waiver requests and state plan amendments. And I want to stress that our work is not done. This is in the true interest of embracing a culture of continuous process improvement. I won't repeat all the stats that the Secretary provided yesterday, but we have seen improved results. We've moved to fast-track approvals for certain routine or prior approved proposals, and for the first time in CMS history, we've approved some waivers for a period of up to 10 years if they've demonstrated success and positive results. This summer, we released a CMC'S informational bulletin that provided an update on the strategies implemented to enhance the efficiency of the state plan amendments and Section 1915 waiver review processes. With this new, more efficient process, we are seeing progress in approval times. Additionally, I will just highlight we've established a twofold, two-step process to expedite not only the routine processing through standardization and to create consistency throughout the regions, but to escalate policy concerns so that we can quickly respond to states about either groundbreaking areas or areas where there is higher risk. These protocols are focused on increasing our accountability to all of you, establishing standardized timelines, and consistency across the regions. It is not and will not be perfect, but we need to hear from you about how we're doing so that we are constantly reevaluating where there are issues and challenges and working to improve that. And I know similarly, we have a lot of work underway with regard to managed care contracts and the rate review process to achieve similar accountability and process improvement. As we move in the direction that affords states more flexibility, we will simultaneously focus on working with you to design robust evaluation of demonstration projects. Data and strong evaluations are vital to our ability to ensure transparency and accountability across states. We've been working to enhance how we evaluate state demonstration projects, including standardizing how certain common types of waivers get evaluated, developing standardized metrics across waivers, and using consistent monitoring and evaluation protocols. We have discussed some of these steps. We've received very helpful feedback, and we look forward to continuing to work with you to improve that process. This administration and our leadership have also recognized and prioritized the importance of balanced regulatory oversight that promotes effective oversight that allows states to keep pace with the way in which care is being delivered and minimizes administrative burden. We've had discussions over the last 2 days about the new managed care rule. I don't want to go into a great deal of detail about that, but I do want to just again acknowledge NAMD, the board members who have participated in the work group to help us identify the areas of concern with the managed care regulatory structure, and we look forward to continuing to work with you as you review the recently proposed rule. And I want to just highlight for this rule, it advances CMS's efforts, or the goal is to advance CMS's efforts to streamline the Medicaid and CHIP managed care regulatory framework and reflects that broader strategy to relieve regulatory burdens, support state flexibility and local leadership, and promote transparency. HCBS, Home and Community-Based Services. In addition, CMS continues our collaboration with states and other stakeholders in the implementation of the Home and Community-Based Settings Regulation. A work group of states and state associations was formed to help us develop flexibilities around a couple of key issues. The results of this work group will be coming out soon, and we think it will strike a good balance in preserving the rule's intent while promoting individual choice and local control. There is much more that we all need to work on together to be clear about our policy objectives to support high quality and safe home and community-based services. All right, 40 more pages to go. You good? All right, so much ground. And I've only been here a month. Imagine how long this would be if I'd been here longer. I do want to touch upon prescription drugs, and certainly you've heard recently announcements by the administration. Certainly Secretary Azar's priorities moving forward is to reduce the price of prescription drugs. We recently announced a demonstration for Part B drugs that will benefit the states because it will hopefully reduce the cost of these expensive drugs and help reduce state cost sharing for the dually eligible. We also recently approved an Oklahoma SPA that will allow the state to enter into supplemental rebate agreements with manufacturers for outcomes-based contracts. Other states I know are considering similar SPAs. This means that the state can absolutely see some of the cost of the drug refunded if the drug isn't working as intended. We've been working with several other states who are interested in pursuing similar supplemental rate rebate initiatives. Finally, we are also looking at providing more guidance to states and manufacturers on entering into value-based contracts. So speaking of value, I want to talk briefly again about the scorecard. As I stressed, we are interested in not only that flexibility, but the accountability that comes along with flexibility. If you can't measure it, you can't manage it. One way in which CMS is working to keep states accountable is through the first public Medicaid and CHIP scorecard. I know this scorecard would not be possible if it weren't for the help of NAMD and all the states that contributed to this first release. Thank you so much for your help. If you haven't had a chance to take a look at it yet, I strongly suggest you do. We've had about 14 states who have spent the last year working diligently with us on crafting this version of the scorecard. We are also this year taking on the challenge of developing 2 additional releases, one in June and one later this fall, or one in the fall of 2019. Future versions will provide the ability to generate year-to-year comparisons and understand differences in state performance. Finally, we are also assessing the ability to include measures that meet key gap areas, such as community integration via long-term services and supports, program integrity, per capita expenditures, and MAGI processing times. And along with that, again, comes the evaluation of the data being submitted. And we do want to work closely with you, because if the data is not effectively representing your work and the experience, then it will not meet our overall objectives of evaluating the performance by state and across the country. Program integrity. We have ongoing work aimed at providing additional accountability to the Medicaid program and to ensure that beneficiaries are receiving the proper care and that taxpayer money is well spent. In June 2018, we launched our new Medicaid program integrity strategy that will bring CMS into a new era of enhancing the accountability of how we manage taxpayer dollars. As part of this strategy, CMS will begin targeted audits for some states' managed care organization financial reporting. Our audit activities will include a review of high-risk vulnerabilities identified by the GAO and the Office of the Inspector General. We will also be working to optimize state-provided claims and provider data. It has been a priority for CMS to work closely with states to ensure that CMS and oversight bodies have access to the best, most complete, and accurate Medicaid data. That is in all of our best interests. In addition to those initiatives, we have a number of other ongoing important efforts to strengthen program integrity, including efforts to strengthen oversight of eligibility systems to ensure timely and accurate processing of eligibility applications and eligibility reviews. In closing, let me say, I am grateful to be working under the leadership of Secretary Azar and Administrator Verma, and to be working with such an incredibly dedicated and talented team at CMC'S and CMS. I know the challenges we face are great, the pressures are intense, and the needs are many. But I am confident that with our shared vision of effectively meeting the needs of those we serve, that together we can support critical changes in the management of the Medicaid program at the state and federal level to successfully demonstrate value to our beneficiaries, to public policy makers, to advocates, and to taxpayers and to providers. Thank you to NAMD, to the board, to your members, to all of you here, and my team for what you do day in and day out to improve the lives of millions of individuals and families in our country. Thank you very much.
All right. Thank you so much, Mary. That was wonderful, wonderful. I just want to reflect a little bit in thinking about that. We talked a lot yesterday about a variety of different partnerships. The public-private partnership that increasingly Medicaid is becoming in this complex world we live in. The panel we did on the deaths of despair, we're talking about state, local partnerships as a way of addressing crises that we really didn't know how to deal with before. But at the end of the day, there's nothing more foundational to Medicaid than the state-federal partnership. And that has defined what we hope to do and what we have hoped to do since the beginning of the program. And so I really want to appreciate the incredible work that Mary and her team and everybody has been doing. Hit the ground running a month in. Sorry you had to miss so many of the sessions we had yesterday, but the ability to take that time and spend it in close conversations with almost every state who's been here is incredibly valuable. So again, thank you for that. That's fantastic. Let me pivot a little bit and also take a point of privilege to bring Judy Moore-Peterson back up here. And reflect a little bit on her and thank her for her incredible leadership and service to Medicaid, to the states, to us as an organization, to this conference and everything. Judy is, as we have said a number of times, our board president. She has been serving in that role for just about 2 years now. And that is the limit of the time of our board terms. And so this will be the last big meeting with which Judy is officially our president. We hope that she will be around for many, many more meetings to come as the immediate past president and in other roles in the future. But I really wanted to do a couple of things. One is, in the true Hawaiian tradition, Judy always comes and brings gifts for people, whether it's a lei that Mary actually got yesterday or 2 days ago, and the one the secretary got yesterday, or cookies and chocolate for the staff or anything. But so I wanted to make sure that we are giving her a gift to recognize her service as board president, and to just really reflect back on the past 2 years, which have been incredibly impactful and important for us as an organization. And I had mentioned that as an organization, we're really not that old. We're only about 8 years old, but we are growing and continuing to mature. And I really wanted to sort of recognize Judy as the board president, as the leader. And obviously it's not her alone. We have an incredible board and an incredible leadership team. But her vision and her guidance and her leadership has really helped us mature as an organization, continue to grow and nurture this conference, continue to grow our support for the states and territories, to essentially create and double down and double down and double down again on our leadership development offerings, and even do such, perhaps, obvious things like develop, create, follow, and enhance a strategic plan, which, quite frankly, we didn't really have before. But all of these things are made possible through, in no small part, due to your leadership and your guidance. And I want to thank you. And on behalf of my staff, on behalf of all the members, thank you for everything that you do. Okay, I'll do that. All right. All right, thank you. All right. On that note, I get the next point of privilege to segue into our next session. We've got, for the rest of today, we're going to do a plenary session coming up right now. We're going to go to breakouts and then finish up with the healthcare journalist panel right after lunch. But I want to sort of take this moment to call up the speakers and the panelists for our next session as I introduce what we were about to do. One of the things that is so foundational to what we've talked about in the past is these different types of collaborations, different types of partnerships, different ways that Medicaid can think about how it's trying to solve the problems that we are all facing. We talk a lot in this organization, in this community, in this world about the social and economic determinants of health, or healthy opportunities, depending on how we want to brand them. And at the end of the day, there's rarely anything as foundational to that as housing. And you really can't think clearly about improving someone's health and well-being until and unless you can address their fundamental housing needs. It's pretty basic on Maslow's hierarchy of needs. And so the next session is really going to address the health of housing and how community and state-based approaches are trying to solve this problem. Because as with many of the social and economic determinants of health, who is trying to solve this problem? It's Medicaid. Is it Medicaid's job to do it? Is Medicaid designed to do it? Not really, but if we don't, or if we don't at least lead the charge, who will? And so I think you're going to see a lot of that reflected here. So I'm going to introduce the moderator for our session, Kevin Martone from the Technical Assistance Collaborative. We've also got an incredible group of folks at the state and local level, including Mary Cantwell, who is the Medicaid director in the great state of California, Flora Arabo from the Enterprise Community Partners, and then Matt Laurie from Michigan. So with that, I will turn it over to you guys and quickly get off the stage so I don't get in your way. But thank you, and we look forward to the conversation.
Great. Thank you, Matt. Good morning, everybody. Housing, right? It's not something necessarily to think about in a Medicaid healthcare space, but I'm really glad we're having a conversation today. We're going to basically spend a little bit of time talking about that intersection of housing and healthcare, and we have a great set of panelists here who I'll facilitate some Q&A discussion with in a couple of minutes. What I'd like to do is really just provide some overview and context for the issue, just so folks sort of get an understanding of what we're talking about. If you work in the Medicaid world, have you thought about what I call the housing health of your community? What's the housing health of your community? And if you're working in the Medicaid space, you're probably like, you know what? I don't really want to take on another issue, right? I already got it. My plate is full. But what I would suggest to you is, we have a national affordable housing crisis that exists out there, and that this affordable housing crisis is also your problem that you need to think about. What does homelessness look like in your community? What's the cost of housing in your state or community? How many people are rent burdened in your state? What's the age of your housing stock? What's your occupancy rate? What's your vacancy rate in your state? How much affordable housing exists in your community? And can you begin to see the correlations between what the housing health of your community is with your health system utilization? And I think these are things that you're going to need to think about as you go through your jobs. When we look at affordable housing, in no state, metropolitan area, or county in this country can a person who is making the federal minimum wage or the prevailing state wage, can they afford a 2-bedroom rental unit working a 40-hour week? It's not possible in this country. When you look about all the available housing resources that might be available through the U.S. Department of Housing and Urban Development, and you factor all that in, we have a net national shortage of over 7 million units of affordable housing in this country. At TAC, every couple of years, we do a report called Priced Out. And in a nutshell, the highlight of that report is nowhere in this country can a person who's on SSI afford an apartment at the fair market rent. Not in Bethel, Alaska, not in Boston, Massachusetts, not in Tallahassee, Florida. Nowhere in this country can a person on SSI afford that rent. And so how does that start to build into healthcare? Well, we know when folks are homeless, we know that they're more likely to use the health system. People who are homeless have higher rates of chronic health conditions, cardiovascular disease, diabetes, bronchitis, HIV, AIDS, asthma, all those things. Almost 33% of visits to the emergency departments are made by people who are chronically homeless. Homeless people visit the emergency departments on average 5 times annually, and the most frequent users visit them weekly and frankly, sometimes daily in particular areas. As many as 80% of emergency department visits made by people struggling with homelessness are for illnesses that could have been addressed through preventative care. And we know that when we look at some of the studies that are being done across the country, when people get access to housing, we know that healthcare costs can be reduced by up to 60%. Emergency department visits down by 60%. Number of inpatient hospitalizations down by, in some areas, upwards of 80%. We also know that when for people with disabilities who don't have access to affordable housing, good quality housing, they end up in inpatient settings like psychiatric state hospitals, IMDs, nursing facilities. And then those folks often get stuck there because of a lack of housing. And those are a tremendous cost to the state. I know when I was mental health commissioner in New Jersey, the average cost for a person who was in one of our state hospitals, when you factored all of it in, was about $350,000 a year in an IMD setting. Those are big, big costs. Now, whereas homelessness and institutionalization are the more visible housing and healthcare challenges that we see out there, there are also a lot of other effects of housing on the health system that Medicaid agencies should be concerned about, such as lead-based paint and asthma. There's 23.2 million people, or 23.2 million homes in this country have one or more lead-based paint hazards. I was actually really surprised at that number. I figured lead-based paint was sort of an issue almost of the past. Those are big numbers. Between 1999 and 2010, there's an estimated 1.2 million cases of elevated blood lead levels occurring among children between the ages of 12 months to 5 years old. When we talk about asthma, nearly half of all the homes surveyed in a national survey of lead and allergens in housing had elevated levels of at least 3 asthma-related allergens. We know that disadvantaged communities are also more likely to have housing stock with structural issues that exacerbate asthma. Asthma is the most chronic illness among children in the United States and one of the leading causes of school absenteeism. And there's 26.5 million people in this country with asthma. And the prevalence of asthma among black children is double that of white children, which also really calls into question for us how we need to consider how racial and socioeconomic disparities in the quality of housing stock may explain some of the racial and socioeconomic disparities in the prevalence of asthma and other health-related conditions. So that's a lot. It's a quick overview context for you of the issue. We're just going to really scratch the surface on this issue this morning, but what I want to do is start to open up some questions of our panelists, I think, who've got some really innovative things that are going on in their states for you all to sort of, as takeaways to take home and say, what can we start to do in this area back in our home states? What I want to first do is start off with Flora. Flora and I have known each other for several years when she was working at the National Governors Association, so it's very good to see her. And a couple of questions that I have. First, for Flora, just generally, enterprise community partners, they do a lot of housing development. But can you describe a little bit more about what the organization's mission is? To me, I know it's definitely broader than that, and I think it's important for folks in the Medicaid and health space to understand what an enterprise does.
Right, thank you. So at Enterprise Community Partners, we are a national nonprofit. We have investments in all 50 states and the territories. We have, over the last 36 years, invested $36 billion into affordable housing across the country. That's a little over 500,000 units, and we're still in a housing crisis. So the way we address the housing crisis is through three components of our work. The first is capital. We aggregate capital. We invest in low-income housing tax credits. We have housing funds around the country. The second is through a bucket I would refer to as solutions. We provide on-the-ground technical assistance all over the country in small towns to help them with their affordable housing challenges. We provide data and other innovations around the country. And then the last is policy. We do have a significant federal policy shop, but we also have a team of staff across the country working in our state houses and city halls all over the country, and that's sort of the work that I oversee in state and local policy. We approach our work very similar to the way you approach yours. I know that for Medicaid directors, it's really this focus on social determinants of health. We look at a similar model, but we look at it through the opportunity framework. So our mission is not just to build affordable housing, it's to develop thriving communities where individuals have access to opportunity pathways that can help them achieve economic mobility. Now, those opportunity pathways are really social determinants. It's access to education, transportation, healthy food, jobs, and so forth. And we actually have investments in all of those things in our portfolio for that reason.
It's been my experience a lot of times from the service delivery side. We're always saying, well, there's not enough housing that's out there. But in my experience, we know housing can be developed. Folks like Enterprise can really cobble the resources together to produce housing. It's not easy by any stretch, but it can be done. But from your perspective, from the housing perspective, for the folks with tenants with complex conditions, healthcare conditions that you see in housing, why is it so important to have access to healthcare services to support them? And maybe even a little bit, what types of services are you seeing that they need to succeed in their housing?
Right. Well, in your opening remarks, you talked a little bit about the impacts of homelessness, but one of the things we don't talk enough about is the impact of housing instability. So we have a lot of rent-burdened people in this country who have housing, but are putting more than 50% of their income into their monthly rent, which means there's less money for prescriptions, less money for food, less money for transportation. These are typically individuals who are much more at risk for eviction and displacement. They move a lot. They have trouble finding new housing. As a result, their children often miss a lot of school. And so it just has this huge ripple effect. So in addition to building new housing, we know that if we can keep people in the housing that we have, we can address like half the problem. And not having addressed that is part of why we have such a huge affordability and homelessness crisis. So, and it's, our tenants are not different from tenants anywhere else in the country. We serve a predominantly low-income population. Not all of them even have health needs, and sometimes not all of them have service needs, but for the most part, they need the full spectrum. And it really depends on the development and the population you're serving as well.
Okay.
Yeah.
I know Enterprise has been engaging in some pretty innovative conversations out there with the healthcare side of the world. Can you talk a little bit about that?
Yeah, so we've been having a lot of conversations with partners, including managed care organizations, around how we can help MCOs do a better job of investing in the social determinants of health. We know that MCOs are very interested in investing in housing and other social determinants, but they do have a real challenge with this free rider problem, where you could invest in a person's housing and a couple months down the road they could be in a new health plan, and so that savings is accruing to a different MCO. So we are working on developing a trusted broker approach. This would be a joint venture between two or several organizations to think about in this massive world of services on the health side that includes everybody that you work with, health plans, hospitals, clinicians, case managers, social services providers, but also all of the people that we work with. We work with housing developers, investors, community development corporations, other community organizations, and tenant service providers, and that's really our wheelhouse. And I think we heard earlier in our introductory remarks, like, hey, is this really what Medicaid should be doing, and who else is doing it? Well, from my perspective, there are so many housers out there like Enterprise that are already doing this work, and the question is, how do we aggregate all of our resources and all of our networks in a way that helps manage the risk? So under this model, it would be the joint venture that would be sort of that would help hold and share the risk, but would also hold and share the savings. So you could envision a state, for example, where we at Enterprise have a very large presence with a lot of units and tenants, and also maybe in that state there are 2 or 3 MCOs that have the lion's share of the Medicaid enrollees. And if we could pool and aggregate not just the resources, but also the risk, then we could find a way to solve for that wrong pocket problem. So that's what we're working on.
It's pretty innovative, yeah. Good, thank you. So Mary, turn it over to the state level a little bit.
Sure.
Several years ago, it seemed to me, I sort of worked the behavioral health side, but also the housing side. And when the housing world would sort of, knock on the Medicaid director's door to say, we need help with housing, that door was usually shut, right? It wasn't a part of the conversation. Why? Because Medicaid doesn't pay for housing, right? But that conversation has changed a little bit in the last couple of years or several years. Can you talk a little bit about how that's changed in California?
Sure. I think really initially it started back sort of even before the role of Medicaid specifically, but with our county community mental health that was not necessarily driven by Medicaid, and funding that the state of California through a voter initiative put out to really allow counties to invest in actually building housing units. And so really then starting to see how that affected the lives of the people who were also simultaneously in the Medicaid program. And so for me personally, and I think our department, really as we were approaching the renegotiation of our 1115 waiver back in 2015, we really wanted to see how far could we push this? How far could we see the connection and explain the connection, and I think the benefit to our colleagues at CMS, so I think agree on how important being in stable housing and having the services that surround that are to not only the health and the well-being of individuals, but the long-term healthcare costs that we would be facing. And so we really started there and wanted to look at how do we improve access to housing services, and again, and I think to the same point made earlier, that it's also stable, that it's not sort of someone's in a place one month and then moving around, and all the additional things that come with not having a stable and safe place to live, whether it's health issues within any sort of housing communities that have serious mold issues or things like that, but also the food insecurity and having access to fresh food. And so wanted to really look at how we wanted to improve that. And so really developed this whole person care pilot program as a test to say, okay, we have 25 communities throughout the state of California, mostly run by local entities, that we were saying we're going to provide federal money through this 1115 waiver to wrap around those things that Medicaid doesn't typically pay for. And we tried to push as far as we could in terms of trying to get Medicaid money for housing, and I think did a pretty good job in terms of what we were able to do and what we were really looking to do going forward. And that was, one, provide the opportunities for counties to come together, and it's the counties, it's their managed care plans, it's provider organizations and community-based organizations to have access to funding that would help them, in some cases, help people find housing. I mean, just the cost of searching for housing, first month's rent, security deposit, those are things that people in our program, very low-income people, have trouble with. And so being able to provide that support, and then for those who need it, particularly those with significant chronic disease or other behavioral health issues, having supportive services actually right there in their community so that they can get them all in one place and not really be in a situation of, because of transportation issues, not being able to get to the services that they need. And so that's really spurred that conversation. We're nearing the end of the third year of that program. And I think seeing a little, really positive results. Small numbers in terms of California, I will admit. It is a pilot, but seeing over 2,400 people who have actually gotten into stable housing, also temporary respite housing for situations where family members, who have been dealing with serious illness really need that type of service. And going forward, as we look through the evaluation of that, how do we then incorporate that into the larger fabric of the Medi-Cal program writ large, where it is sort of just a part of the services that our health plans and that the department is providing?
Yeah. I know, in a state that's as diverse as California, it's vast. But in particular areas where you have big homeless numbers, so let's say like Los Angeles, are you seeing any good innovations coming out of the local managed care groups in terms of how they're trying to approach these issues and even sort of utilize the waiver services and other services that are available through Medicaid to really support those interventions?
Yeah, and I think it's grown because of the whole person care pilots, but even before that, I think we have had many of our health plans really recognizing again the impact and in the end, the impact to their own cost of healthcare services to our beneficiaries. And so we have several health plans who have been doing things even prior to whole person care, where they're connecting with local shelters, actually having community navigators out there to help connect people not only to the healthcare services that they need, but what other social services might they be able to be eligible for, and how to get them into that and really support that. We also have plans who have set aside funding for actually subsidizing housing from their own reserves, not using Medicaid money, just to be clear to my CMS colleagues out there. But really doing that, and even a few plans actually building units, and it's pretty amazing. So we have in Los Angeles, again, a large county. These are small numbers for that, but funding 300 supportive housing units in the county to try to really have a place where people can get the services that they need. And we also, and again, very diverse communities. We have Central California Alliance for Health, which covers 3 of our more coastal northern counties, and they are actually involved in the construction of permanent supportive housing units to really, again, have that starting point of having someone be able to live in a stable environment, and then what we can do to then bring services to them, help them get transportation to the services that they need to get to if they need to get to a doctor's office, and helping to understand the nutritional aspect and really nutritional counseling, and where can we get sort of fresh foods and things like that, and particularly in some urban areas and others, it's much more difficult or much more expensive to get to there.
California and other states have done this too, have invested a lot of capital dollars into housing.
Yes.
And the questions are then, well, who are we going to serve? And sometimes it just gets complicated in terms of target populations, specific disabilities. You get into some fair housing, challenges and things like that. But at the state agency level, what types of conversations have you really engaged in with, for instance, the Department of Housing and Community Development, the state housing finance agency in your state?
Yeah, so we actually have a housing financing council that exists in California that just started last year. I represent the Department of Healthcare Services on that. Variety of departments participate, state agencies, including housing and community development. But also we have advocates and consumer stakeholders who are participating to really bring those community-based organizations to the table to help us really think about what is it that we're trying to accomplish. I'm also very fortunate to live in a state that is highly committed to funding ways to help in this housing crisis. And so just last week, voters approved another $2 billion to really be invested in developing housing, particularly targeted for those experiencing mental illness, allow with housing insecurity. And then again, but ongoing through other state and local initiatives, that's another $1 billion on top of that. And so we really are working together on that. And the purpose of the Homeless Coordinating and Financing Council really is to try to, how do we bring all of those initiatives together? Because there's so many things happening in different communities, and certainly different communities need different solutions, but how do we have a statewide database of what are the housing sources that are available, who's building what, we don't want to be duplicating efforts to the degree we don't need to, having a comprehensive list of state programs that people can access, depending on what their needs in terms of housing support is, as well as developing an actual statewide need assessment. Seems like something you probably need, but we don't actually have a statewide assessment. Counties and local entities all do their own assessments, but how do we actually have everything in one place so that then as a council and recommending to the governor and the legislature, these are the things that we actually need to do on a statewide basis.
Okay. So Matt, in Michigan, you have sort of some broad perspective within your department. What kinds of things are you guys doing in Michigan in your department to sort of bring together this housing and healthcare conversation?
Well, I'm fairly new. Good morning. I'm fairly new to the bureaucracy of state government, just about 4 years in my current position. But, housing did not come naturally to me as far as something that we should devote time and resources to. But, my attitude has greatly changed. And I think, if I can sum up, anything I'm going to say here this morning is housing equals stability, and on a lot of fronts, and we've kind of touched on that sort of thing. But Michigan Department of Health and Human Services is kind of the coordinating point for our housing efforts. We've got a lot of partners, but we've got about $30 million, that we spend, and that's in the totality of housing, and so that includes rapid rehousing, emergency shelter, all that, and Michigan's got about roughly 69,000. Homeless people, and so $30 million over 69,000 people is not a lot, and we're trying to partner with others as we move ahead, and coordination with other partners I think is the key to success. One of the things that the governor implemented I think in 2016 was our state interagency council on homelessness. It's not only the Department of Health and Human Services, but it's Department of Technology Management and Budget, groups like Volunteers of America, our State Housing Authority, Department of Military and Veterans Affairs, et cetera. But again, this council is focused on trying to partner and talk about not only housing but healthcare, jobs, income, et cetera, et cetera. So we first started working on housing I think 3 years ago in partnership with the National Governors Association. The department then, when I first started, 4 years ago, was the Department of Community Health. We then combined with the Department of Human Services. We got the Department of Health and Human Services now, and that was really that combination was really good, because at that time, we started looking at housing, and then all of a sudden we realized, hey, in another state department, they're talking about housing too, and really led us into some of our partners that we're working with today, including MISTA, our state housing authority. So. It's all about communication. It's all about trying to open doors and find out who's doing what and how they're doing it, and trying to do it the best way possible.
I mean, certainly hear from the panelists, sort of this coordinated planning, and I know that was my perspective in state government. You could have, someone from the state mental health agency go to the housing folks and say, we need this type of housing. and then someone from the Developmental Disabilities Agency go to the housing group and say, we need this type of housing, and someone from TBI would go have the same conversation. And if you're on the State Housing Finance Agency perspective, you're like, what are we doing here? And sort of to have that level of coordination, I think, is really important in sort of pushing those things along. Matt, in Michigan, within a department, are there conversations? I mean, one of the things that I often see is, well, there's a lot of pressure on Medicaid to pay for a lot of housing supports and things like that, but we also know Medicaid can't pay for everything. And then at the same time, within maybe the other single state agencies on behavioral health, for instance, are there joint conversations about how you could sort of pay, budget resources to pay for the types of services that are needed? I look at it as, if you look at the range of services that a person may need to succeed in their housing, some of those services may be paid for by Medicaid, but some aren't. And the question is then, how are we going to get those other services paid for? And how does that planning go on at the department level?
Well, as I told you, I've kind of evolved into housing, and I think it's a priority for me, and I think Medicaid should pay for my projects. But,
Mine too, it's not just you.
but I do understand, and being a team player, and our Medicaid division has been absolutely fantastic in this project and trying to work together. They've been on board. Again, I'll go back to when we first started with the NGA. We had a couple of the employees from our Medical Services Administration on board. They bought in, and like I say, our acting director now has been absolutely supportive. How do we do that? We got a ways to go, and I think communication with groups like Flora and talking with states like California, and we had the opportunity to go to California a year ago and go down to Skid Row and actually look at massive homeless issues, and you take all these bits of information, you put it all together, and hopefully you can come up with a plan in your state that's gonna make things work. Medicaid obviously is not going to be the payer of last resort for housing, but I think some of our partners that we have developed in Michigan, and I'll give a plug for one of those, is United Healthcare. And I just found this out a couple of weeks ago. United Healthcare has invested about $35 million in the past 2 or 3 years in Michigan alone in housing. And I think nationally they're up $350 million. And so like I say, as we develop partnerships, I think we're going to get there.
Now, Michigan participated in the CMS Innovation Accelerator Program on state Medicaid and housing agency partnerships. I think California did. I know Judy, Hawaii did. Can you talk a little bit about, and Michigan had some innovative things come out of that, and are you able to talk a little about some of the data integration efforts and the permanent supportive housing pilot that came out of it?
Yeah, and again, Medicaid was excited. Our Medicaid division was excited as we move forward, trying to develop an action plan for data integration. What does that data mean? Frequent users in our supportive housing pilots, broader policy work. How does that all fit together? Again, Medicaid very interested in the data piece for a couple of reasons. What's the percentage of homeless individuals out there who are not on Medicaid? And then the second issue was frequent emergency users and/or high-cost claims individuals who are there out there too. How can we take a look at those two and use that as a moving forward? Also, our Medicaid very interested in tenancy supports, and I think. That's difficult, and I was talking to Flora, before we came up on stage, this almost seems like a never-ending battle. We provide housing for a house or an apartment for somebody, then we got to look at tenancy supports. Well, the next thing we got to look at is transportation, so we can try to find them a job, and then we got to make sure they're healthy. And I come from a Republican state. That's going to change January 1st with a Democratic governor, but we still have a Republican legislature, and again, sometimes that's difficult. The prevailing attitude sometimes is, pick yourselves up by the bootstraps and solve your own problems. And we all know it's not that easy. But so those two type of things. And who's out there, that isn't on Medicaid that could help us, help the taxpayers, and then who's our frequent flyers, those who are costing us a lot of money, and trying to identify those and focus on that.
Yeah, I think what's important for folks in the audience to know also is when we talk a little about there are housing resources available. And it's not easy by any means, and you often hear about all the waiting lists on Section 8 and things like that. But last year, Congress did appropriate a lot of new money for rental assistance for people with disabilities in this country through two main programs. One is the HUD Mainstream Voucher Program, and the other is the HUD Section 811 Project Rental Demonstration Program. And we actually think that between those two programs, that HUD will fund probably nearly 50,000 new units of affordable housing in the country in the next couple of years for people with disabilities. And primarily, the 811 program is a little bit smaller, and those funds come through state housing finance agencies. But the mainstream vouchers come through public housing agencies. And in each one of your states, there are several public housing agencies. And those public housing agencies are basically going through the process of applying for those funds. What's unique in the past couple of years, and this is from some of the relationships that have developed between HUD and CMS, is that HUD is requiring the PHAs to demonstrate that they are working with service partners in their local communities. And that's really important, and that's even important at the state level to know, what's going on down at that local level in order, how do we make services available for folks who are going to gain housing through these new vouchers through the PHAs. And so those are some of the types of relationships sort of down at that local level. I think, Matt, you were talking a little bit earlier about sort of that local level planning. I think it's I sort of think about it as horizontal planning, right? We do planning horizontally across the state agencies, but it's the vertical planning downwards with the local communities that's so important here too. I want to give the panelists sort of a minute or two to see if there was any reactions to anything that anybody said up here. I know I saw a couple of you sort of jotting down some notes. Any reactions from any of the panelists' comments?
Other than, if you're gonna fund Michigan, definitely fund California. I think really interesting to see what's coming out from, I think, North Carolina's recent waiver. Really interested to hear about that and what sort of experiences we can have. I think, the approach that we've tried to take, given some of the limitations of the Medicaid side, and of course understand Medicaid is not a housing program, has been really getting our local communities who are participating in these pilots to recognize that in the end there is healthcare savings, and actually then them being able to reinvest that savings into housing. So we do have 7 of our pilots who have separately, so it's not technically part of whole person care, but have separately created these housing funding pools that are going beyond what we're allowed to do in terms of just initial tenancy support services and actually providing rental subsidies. And so if you can sort of braid together the different entities who have different types of funding and then see who's saving money somewhere, if everyone's really willing to work together, you actually can do a lot more. And so I think it's challenging. I think all of us who work in state government know lots of silos can exist and people want to do their own department stuff. But I've been very encouraged both at the state level with the partnerships, particularly of those of us on the council, but also at the local level, really seeing the counties, the health plans, the behavioral health entities, and the housing entities really getting together and saying, well, if we look at what we all have, we can create really this braided service of being able to provide that full spectrum for those people who need it.
So, Matt, as a former legislator, so we hear savings, right? We hear budget savings, great. Is it possible to think that we can sort of plan budgets sort of across state agencies with sort of these common interests in mind, so that when we're starting to think about, savings that might be realized in a Medicaid program, how can we then, support folks in housing? I mean, the bottom line at the end of the day is, when it comes to housing, we need money for capital, but we also need money for just rental assistance, right? And rental assistance, when you think about the cost of serving someone in institutional settings, like I was talking $350,000 a year in a state psychiatric hospital, to $7,000 or $8,000 a year for a housing subsidy. Any thoughts on that or reaction to that?
I think legislators are, and myself included, when I was in that position, we're always in a hurry for, I need the savings next year. We're working on next year's budget. We're going to do X. Okay, well, how much is it going to save next year? But in this particular case, we're talking about housing, we're talking about stability, we're talking about healthcare, we're talking about jobs, we're talking about food security. I've come to realize it doesn't happen that quickly, and to answer your question, yes, I think so, but I think we're not going to have that immediate return that everybody's looking for, and I think we all here in this room have to do a better job of selling what we're doing and explaining that. And I think, part of my awakening as far as housing was, I come from Southwest, rural Michigan, cornfields, primarily white, didn't have any exposure to the urban environment till I got to Lansing and lived up there for a while and started looking around and seeing things that I never thought of. And I never would have voted for busing. Who needs a bus? You look at our bus in Southwest Michigan, there's 2 people on it. Why would I pay for that? Those type of attitudes. If you haven't seen it, if you don't know it, it's hard to vote for something. So I think doing a better job, pulling legislators actually into our urban environments where this type of thing is happening, taking them to some sort of I can think of the housing authority in Los Angeles took us to a building where they've got semi-permanent clients, working with them. They've got a stable place. Yep. It's showing they are saving money. So
yeah. And I think I saw Margaret from Alaska earlier in passing, but I know we were doing some work in Alaska several years ago, and in the very rural and frontier areas, sometimes it's not about new development because just the cost of new development it's just prohibitive. You can't do it. But it's at that point, it's how can we sort of protect the housing that people do have? Mm-hmm. How can we enhance it? How can we weatherize it? And things like that so that they can stay in their housing and succeed. It just, when you sort of think about the vastness of the housing issues in our country, it's a challenge. Mm-hmm. Florida, in terms of, one of the things that we talked a little bit about were disparities. Mm-hmm. Can you talk a little about the interconnectedness of health disparities with other types of disparities and the role that housing can play in addressing these issues?
Yeah. I know that this is a group here that is really concerned about health inequities in their states. We see really disproportionate health outcomes between white people and people of color. I will say that from the work that we do, we're very concerned about patterns of racial segregation. Now, in the housing world, we're serving essentially the same population that you're serving. If we pull up any community, we'll probably see significant overlap in who we're serving. We have a platform called Opportunity 360, which is a data set that lets us pull up any community in the country. It's available to the public, and you can just look at a variety of indicators on health, housing, stability, environment, transportation, even air quality. And what we're finding, we spend a lot of times with maps, and what we're finding is where we see these disparities on maps between health outcomes are the same disparities in income, in race, in educational outcomes. I mean, the list goes on. And so we're really laser focused on how we can reverse those patterns of segregation. We're also, it used to be that in the housing industry, we would invest in housing, and then that was kind of it in general. And in doing so, and just investing in the housing, a lot of housers were unintentionally perpetuating concentrations of poverty. Mm-hmm. And so even though a lot of the projects that we work on now don't serve our population directly, our tenants, we spend a tremendous amount of money and effort into community building. So if we're gonna build housing in a community that's suffered from disinvestment for years or often decades, we are going to be looking at how to improve the schools, how to provide early learning centers, how to green some of the spaces and make sure there's adequate jobs and transportation. Sure. We actually have investments in all of those things in our portfolio. We have a great pilot in the, it's not really a pilot, sorry, it's a program in the state of Washington. We're combining early learning centers with affordable housing so that some of the new affordable housing developments in the state would have early learning centers on the first floor. There's a huge early learning shortage in Washington, and being able to have access to that, call it childcare, early learning, whatever you want, solves a really big problem at the community level.
So I want to see if anybody has any questions in the audience. We're wrapping it up now? Okay. Yeah, so Matt's like, we're done. We're done. To housing, Medicaid directors have had enough of housing. I would suggest in closing, from a Medicaid director's perspective, housing is an issue for you. And I think, you really need to sort of take back and consider, what role do you have in increasing or influencing the supply of housing? And you say, well, that's not my role. Well, it is your role in some respect, because you can go talk to your housing finance agency, for instance, in terms of, how do we increase the supply of affordable housing for folks? What is your role in terms of improving the quality of housing that exists in your communities, right? So when we talk about the asthma and the lead-based paint, if you're seeing big numbers of these issues in pockets of your state, can you take your data and go work with those local communities to try to improve those things? And what is your role in terms of making sure that there are the right types of services and supports that exist for people who need them in order to succeed in their tenancy in community-based housing? So I think those are 3 takeaways for you in terms of what is your role in a state Medicaid agency and how does it relate to housing going forward. So I think with that, let's thank our panelists, and we'll go from there.
Thanks.
All right, thank you so much, Kevin. That was great. That was fantastic. I hate to cut off the Q&A, but we were already eating into our break, and I want to make sure that people have a time to sort of actually come up and ask questions if you want. But we are reconvening in our breakout sessions at 10:45, so that gives you about 20 minutes or so. Get up there, see your friends, and then we'll reconvene back here at noon for lunch, and then the health journalist panel. So thanks, everybody. That was great. That was great. Thank you. Thank you.